ನಮಸ್ಕಾರ. ನಾನು ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದರಾವ್, ಮೈಸೂರು. ಇಂದು ನಮ್ಮ ಜೊತೆ ಪ್ರಖ್ಯಾತ ನರರೋಗ ತಜ್ಞರಾದ ಡಾಕ್ಟರ್ ಸೋಮನಾಥ್ ವಾಸುದೇವ್, BGS ಅಪೋಲೋ ಹಾಸ್ಪಿಟಲ್, ಮೈಸೂರು ಇದ್ದಾರೆ. ಅವರು ಇಂದು ತಲೆನೋವು, ಹೆಡ್ಏಕ್ ಬಗ್ಗೆ ಮಾಹಿತಿ ತಿಳಿಸ್ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಅವರನ್ನು ನಾವು ಸ್ವಾಗತಿಸೋಣ. ಡಾಕ್ಟರ್ ಸೋಮನಾಥ್ ವಾಸುದೇವ್.
Talking on only the main types of headaches and what we should do and what we shouldn't do. So, the commonest symptom in the world, anywhere, commonest symptom in the world is pain, and the commonest pain is headache. It's so common that all of us, most of us in this room itself must have at some point or other had headache due to various reasons. There's a international headache society which gives all the recommendations and classifications of headaches, and so it was established in 1988, and now it was revised in 2018. This is the third revision, and this is now this is called the ICHD-3 alpha, which is the International Classification of Headache Disorders, which was revised in 2018. Well, this is divided basically into two. One is the primary headaches and then the secondary headaches. So primary headaches, when there is no obvious reason for a headache, or whatever, all examination, all investigation shouldn't show any abnormality. And there are four of them: migraine, tension type headache, trigeminal autonomic cephalgias, where we have pain in the distribution of the trigeminal nerve along with lot of autonomic symptoms and other primary headaches. The second, the rest of the 13 headaches are secondary headaches. The first four are primary headaches. The rest of the total 13 are secondary headaches. That is due to some other cause in the head. So, for instance, it could be due to trauma or injury to the head. It could be due to cranial cervical vascular disorders, due to non-vascular intracranial disorders, due to substance abuse or its withdrawal, headache attributed to infection, headache attributed to disorders of homeostasis like hypoxia, hypercapnia. Headache or facial pain attributed to disorders of the cranium, that means ENT, dental, all those causes. Headache attributable to psychiatric disorders, painful cranial neuropathies like trigeminal neuralgias, glossopharyngeal neuralgias, and other facial pains, other headache disorders, of which about 80% of them are primary headaches. So most of the headaches in our society are primary headaches. Whereas most of those people, for the lay person, every headache is sinus headache. They will come and tell us, I've been having sinusitis for the last many years. That is what they say. They don't even tell a headache. I've been having sinus headache for the last so many years. Commonest cause for headache in the society, lay persons, is sinusitis. Whereas it's not true. 80% of them are primary headaches. And the secondary headaches are only about 15 to 20%. So all the other causes, and many of them first diagnosis, especially nowadays after all this googling and all that, first diagnosis would be a brain tumor. They come with this telling that I have a headache, I need a scan because I suspect I have a brain tumor, and all that is due to googling. So that is due to manifestation of an underlying disease or disorder. The primary headaches, of which the commonest primary headache is tension type headache and migraine. Sometimes we see more migraines than tension type headaches, but the commonest according to literature is tension type headache, and then we have migraines, and then we have other all the other headaches which form only about 5%. Primary headaches, whereas the secondary headaches, the commonest would be headaches of systemic infection. Any systemic infection like the viral, any systemic infection headache, and then due to head injury. And the other rest is all about 8 to 78%, like vasculitis, drug-induced cerebral hemorrhage, and all those things. I will be talking basically about migraine and tension type headache. These are the two commonest primary headaches in this world. And migraine again is divided into 6 or classified into 6 different types. Migraine without aura, where we have no aura, just the headache. Migraine with aura. Chronic migraine, when we have migraine for more than 15 days a week for the last 3 months, it's called chronic. 15 days a month for more than last 3 months, it's called a chronic headache, chronic migraine. Complications of migraine, like you have status migrainosus or migrainous infarction, or migrainous aura without continued aura without infarction, and all those things. Probable migraine, where we have features of migraine, but they have very few attacks, less than 5 attacks that totally so far. So it could probably migraine, and episodic syndromes that may be associated with migraines. There are 6 different types of migraine. And then we have got tension type headache, where again there are 4 different types of tension type headache. There are infrequent tension type headaches, frequent tension type, episodic tension type headache, chronic tension type headache, and probable. Just like migraine, this also probable when the number of attacks are very few. Then you don't know whether it's really tension type headache or not. So the next we have is trigeminal autonomic cephalalgias. That means that we have headaches in the region of the trigeminal nerve distribution, or pain, any type of pain in the distribution of the trigeminal nerve distribution, along with autonomic symptoms, like you will have conjunctival ingestion, you will have tearing from the nose, tearing from the eyes, nose, running nose, and all those things. So there are different types of trigeminal autonomic cephalalgias. The first common one is cluster headache, where you get clusters of headaches every day, daily, in one cluster for a few days. Suddenly it disappears. Then after a few months, days, years, it may again come. Another cluster, where again you get headache daily, almost at the same time, maybe 1 or 2 times in a day, but comes at the same time every day. Most of the time it will be coming at the same time. There will be headaches. And short-lasting unilateral neuralgic headaches associated with conjunctival injection and tearing, sunk, hemicrania continua, and probable trigeminal. Again, this is probable because number of attacks will be very few to make a diagnosis. Other primary headaches like primary cough headache, primary exercise headache, primary headache associated with sexual activity, primary thunderclap headache, cold stimulus headache, external pressure headache, primary stabbing, all these things are not very common. So I'm not going to be talking about those. I'm just going to be talking about the 2 most common headaches in our clinical practice. And secondary headaches, as I told you, it's always due to trauma. I've already told you about that: cervical vascular disorders, non-vascular disorders, intracranial disorders, substance abuse or its withdrawal, headache, attributed infection, homeostasis, headache, ENT, dental, and all the other headaches. Now, when you get a headache patient, what we do is the most important thing is the history. You have to take a lot of time to take the history, because they will be telling you all these things. You have to look at the what, because there are so many. You saw there are 14 different classifications of headaches. There are so many causes of headaches. So you need to find out really what it is to decide what you are going to do, investigate, and how you are going to treat the patient. So you have to look at the age of onset, because we have seen mothers bringing their children about 1 year, 2 years, 2 years old child. They will come and tell that the child has got headache. Headache is the mother, not the child. A 1 year old child can never tell that I have got headache. So whenever somebody comes to, you have to look at the age of onset. Especially those patients who are getting a headache above the age of 40 years. Again, that's a red flag. You have to look for causes for headache in that above 40 years of age. They are late onset headaches. You have to always be careful, because you may end up getting some abnormalities in the brain. So age of onset. Most of the time, this migraine headaches will start in the young adults. sometimes in children also, but in very small children it will be, in young children, very young children it will be what's called as migraine equivalence. They will have just sudden attacks of vertigo. They just, while playing, suddenly they stop. They just tend to, tend to fall. They just hold on to something. A few seconds they are back to normal, go back to their play. That is called as childhood paroxysmal vertigo of childhood, which is a migraine equivalent. So it can start in very young children also. So that is one thing. So headaches usually, migraines usually start in adults, young adults or children, and it continues for many years. So then the frequency and duration, how many times in a month, in a day or in a year you are getting headache, and how long it is going to last. Usually migraines keep coming frequently depending upon the triggers that they are exposed to. So they usually come on, if it's more than 15 days in a month for last 3 months, then we call it as chronic migraine. And the other trigeminal cephalalgias, autonomic cephalalgias, which like cluster headache, usually last for about say 90 to 120 or 120 minutes, 2 to 3 hours max. Migraines usually last for about 1 hour to 72 hours. So these are the you have to look for what is the duration of the duration of the headache. They have very short lasting headaches, just like a thunderclap. It's called thunderclap headache. So depending upon the duration of the headache, you can come to know what type of headaches we are dealing with. Then the early warning symptoms like, especially elderly persons, having headaches early in the morning. Whenever you get headache early in the morning, waking up you get early in the morning headache and you start vomiting, that should raise a suspicion of raised intracranial pressure. So this is something which should be in your mind. Other symptoms like blurring of vision, sudden blurring of vision for a few minutes or a few seconds. It's called as transient obscuration of vision. When they complain of this transient obscuration of vision, again, then we are dealing with something called as idiopathic intracranial hemorrhage. So there is a raised intracranial hemorrhage. It might be idiopathic intracranial hemorrhage. Yet again, systemic hypertension producing, that's another misconception in our society, both among the public as well as among the doctors. As soon as you get headache, they tell you go and check your BP. They go and check the BP. BP will be 150 by 100 or 160 by 90. They said you have headache and you have hypertension. Your headache is due to hypertension. Put on antihypertensives. This is a wrong thing. For systemic hypertension to produce headache, it has to be a long-standing hypertension, and they should have a very high diastolic, more than 160 by 100, diastolic about 120, and constantly for many days. You will be getting a headache mostly in the posterior aspect, occipital regions. Early morning headaches. These are typical of headaches due to hypertension. As I told you, one of the causes of headaches are hypertension that comes in the another group called secondary headaches, and that is way down the list. Very few cases of hypertension producing headaches, unless it's a hypertensive emergency where you get raised hypertensive encephalopathy where you get raised anxiety and all those things. It's very rare for hypertension producing. The BP that was recorded is due to the headache. The BP which was raised is due to the headache. So you just have to be careful. Just wait. Take care of his headache. Once the headache comes down, check the BP again. BP would have come down. So instead of starting an antihypertensive, just treat the headache. Aura, you have to ask the patient for any aura. Aura may be any sensory symptom or motor symptom also. Sensory symptoms like you can get a visual aura, you can get any of the sensory aura. Visual, it can be sensory, somatic sensory, it can be motor, you can get weakness, you can get one-sided, we call it as hemiplegic migraine. You get one half of the body will be weak, lasts for a few hours and then resolves by itself. And if it lasts longer, then you have to suspect a complicated migraine where there is already infarction happening. So other associated symptoms like nausea, vomiting, photo and phonophobia are very common with migraine. Other symptoms like, as I told you, the autonomic symptoms of ptosis, meiosis, tearing from the eyes, nose, and all those things. you have to, that gives you an indication that it could be a trigeminal autonomic capillarities. Then you ask for the precipitating factors. What are the triggers? Most important in migraine is looking for this precipitating factors, which I will come to later. Aggravating and relieving factors, any previous illnesses, any drugs or any habituations, personal history and occupational history. Some of them may be having headache because of the stress in the office. So all these things have to be taken care of, and then you go examine the patient clearly and very carefully. Most importantly, look for any features of raised ICT. If you are not confident of looking at the fundus, they may be having mild lateral rectus palsy bilateral, which is again symptom of raised ICT. But if you have an ophthalmoscope looking into the fundus, is the best thing to look for any raised ICT. Look for neck stiffness, to look for any intracranial infection or intracranial bleed like subarachnoid hemorrhage. All these things, once you do a thorough examination, you will come to know, you can very easily come to know what is the type of headache. And the commonest headache, as I told you, in our clinical practice is migraine, which manifests as recurring attacks, usually lasting for about 4 to 72 hours. And this can interfere with normal functioning, involving at least any 2 of the following characteristics. Unilateral location. It need not be always unilateral, it can be bilateral. But it is unilateral most of the time, and it keeps alternating. Now, whenever you have a headache which keeps on happening only on one side, then you have to think of other alternatives, like a cluster headache. So always on one side is usually not migraine. Maybe on right, maybe on left, alternatively, or more on one side. So that is more suggestive of migraine. Moderate to severe intensity and will be throbbing in nature. That's because of the pulsations of blood vessels, and worsening with routine physical activity. And during headache, any one of these symptoms may be there, like nausea, vomiting. Most commonly nausea, vomiting may be seen in extreme cases. No evidence of organic disorders could be there, which will cause headache. Now it's a very major health issue. I feel at least about 40 to 50 or 60% of the population will be having migraine. Very, very common, and very few of them come for treatment from the doctor, because even FM radio treats migraine with telling dart, take dart. You know, many of them take dart because FM radio says so. So that's very few of them come, but that's okay. If it is migraine and if they take a dart, it is fine. They may be getting very infrequent headaches. You take a dart or whatever analgesic is fine. They be okay with that. That's okay. That is a treatment anyway. We are also going to do. But the problem issue is it should be migraine. And if it is migraine and if it really affects them, they need to take treatment. Usually happens when the patient is awake, usually unilateral, and then these are all already I have told you about nausea and vomiting. And photophobia and phobia, they will be telling that they get irritated when the husband talks to them or the wife talks to them. Now somebody talks to them, that photophobia, and they don't want to sit in the light, they go and sleep inside a room in a quite dark place. That's very common, and about 60% of them report a prodrome, often occurring few hours to a few days before headache comes. Some sort of irritability will be there. And pathogenesis, I'm just not going to, it just means, in short, what happens is there are certain centers in the brainstem called as locus coeruleus and raphe-nucleus, which actually gets stimulated by these triggering factors, and then when the triggering factors happen, they release neurotransmitters which go and stimulate the trigeminal nerve, and then they get pain in the distribution of trigeminal nerve. So these are the usual neurotransmitters which are nociceptive, like 5-hydroxytryptamine, substance P, CGRP, calcitonin, gene-related peptides. And so there are certain of these neurotransmitters which produce or stimulate the pain pathway and produce pain. So any of these triggers like stress, glare, noise, the patient's internal shock, the dilation of internal and external character, or other factors activate the specific centers in the brain, and that's what happens. And there will be constriction of the intracranial vessels and dilatation of the extracranial vessels. The dilatation of the vessels on the scalp, and that is responsible for this throbbing pain. When the vessel dilates, you get, and that's why they tie a kerchief or something around when they tie it, they actually compress the temporal vessels, the temporal artery, and they get relief from the pain. That's just one of the treatments, whatever layperson's treatment. And so it's because of the dilatation of this that they get headaches. But there will be dilatation in the meningeal vessels also which produces headaches because meninges are pain sensitive. The triggers, this is something you should be asking the patient whether they are taking their food on time, whether they are taking any specific foods like normally chocolates, all the cold drinks, ice creams, cheese, butter, ghee, all too much of spicy and oily foods usually. Excess of coffee and tea. They will ask, many of them tell, the wife will be complaining, he keeps on drinking tea because she has to make tea. He keeps on drinking. Whether that is, okay, that poor fellow may be drinking only 1 or 2 teas in a day. Excess of coffee and tea is again a cause for trigger for headache. And sleep, either oversleeping or lack of sleep, especially sleep at night. Many of these youngsters nowadays working in this IPAP do get migraine because of this, migraine and epilepsy because of this. Emotional factors like mood swings, environmental factors like most commonly you ask them when they go, do you get headache when you go for a marriage? Nowadays marriage reception, there will be a full of lights, glaring lights, and there will be in a small hall there will be a orchestra there inside the hall, full of noise and light. 100% most of us will get headache. So these are the triggering factors. And the hormonal factors like pregnancy or contraceptives, hormone replacement therapy, and all these things are again triggers for headaches or migraine. Now, when do you investigate? Usually, when you get such a patient with migraine, you have to you most of the time will not need any investigation because somebody who's been getting a migraine as attack, if it is typical migraine attack for many years, it keeps on alternating. Examination wise is normal. Then most of the time you will not need a CT even. But whenever you get a sudden onset of severe headache, when they have got atypical headaches, when there is fever, neck stiffness, and there are any neurological symptoms, especially new onset other than headache, altered mental status, cognitive behavioral disturbances, they may be becoming apathic, dull, they may be having urinary incontinence, all these features of raised ICT, abnormality, when you examine you find any abnormality in the neurological examination, or anybody having headaches first time, initially after the age of 40 years. And those you are having headaches with exertion of sexual activities, training, all these are pointers to intracranial pathology. Now, whenever you have this, you go for neuroimaging and then you try to rule out anything. So, neuroimaging is one thing you can do, either a CT scan or an MRI, and once that is normal, then you know that there is nothing which is secondary, causing secondary headaches. You can also do other investigations when you are suspecting vasculitis, all those things, for looking the common investigations like CBC, ESR, arthritis workup, and all those things. And when you get a patient with migraine, you have 2 types of treatment. One, non-pharmacological and pharmacological. I always stress on the patient about the non-pharmacological. They are also happy. If you tell them that, okay, you don't take treatment, you should not tell them you don't take treatment. You should tell them the more important one is the non-pharmacological approach. The non-pharmacological treatment is trying to avoid, first identifying all your triggers of migraine and then trying to avoid those triggers of migraine. That's very important. So whenever we have that's the non-pharmacological. The pharmacological treatment is about again we have acute abortive therapy and the chronic oral preventive therapy. The acute abortive therapy, those is good, like what FM radio itself is. Take a dart, or take any painkiller, or take any other NSAIDs or abortive drugs which I'm coming to. Or the next is those people who are getting headaches very frequently. Then they are more likely to be needing a prophylactic therapy where they have to take treatment daily to get rid of the headaches, and then we taper off and stop the medications after a period of time. There's the same in acute therapy. We have got in mild cases NSAIDs, it can be single or combination, or 5-hydroxyprotein agonist. In moderate migraine, you can take 5-hydroxyprotein or dopamine antagonist for the nausea and vomiting. In severe cases, may have to give either subcutaneously, intramuscularly, 5-hydroxytryptamine agonist, or IV paracetamol is available now. IV dopamine antagonists are there, and nowadays we have got intranasal sprays of triptans. So that's also useful, very useful in these cases of very severe headaches. The prophylaxis goal is to reduce the number of attacks and improve your quality of life and improve the function and reduce disability. Now, if successive therapy is maintained with prophylaxis, then you can consider a taper of prophylactic medications even 3 months after 3 months you can start tapering and stop. Some people may have to take it for a longer time, and the usual drugs which are available for migraine prophylaxis are beta blockers commonly, but just ask them for a history of bronchial asthma. The bronchial asthmatics will be taking all these beta agonists, and that will even trigger headache. So, and when you give beta blocker, asthma will be worsened. So just be careful about that. Tricyclic antidepressants like amitriptyline is very common, but many of them can say that they find it very difficult to get up in the morning. Just tell them to take amitriptyline earlier in the evening, by around 7 o'clock. They'll tell her, sir, no problem, you can take, nothing will happen. You take it in the evening so that they will not have a problem getting up in the morning. And other antidepressants like fluoxetine also may be useful, but antiepileptic agents like sodium valproate, sodium valproate is a good agent, especially in those lean patients, those males. Better avoid in ladies because they will have weight gain, they will have hair fall, and then they will go to the dermatologist for treatment of hair fall. Okay, so these are the problems with sodium valproate, but these are also very good drugs. So whenever you have an obese patient with migraine, because all the drugs used for prophylaxis in migraine will produce weight gain except topiramate. So topiramate is a drug which can be used in obese patients, and then calcium channel blockers is flunarizine, the common 5-hydroxytryptamine antagonist, dense. Botulinum toxin, newer drugs like botulinum toxin that you give into 31 sites over the scalp, into the muscles. Intramuscular injections of botulinum toxin is given in some cases of chronic migraine who do not respond to any of this. It's very good, very useful, but problem is the pain during the injection. Some people can develop ptosis, some people can develop weakness of this muscle, so they will not be able to wrinkle their forehead. So these problems are there, and it's of course expensive. And then we have got some other agents nowadays, the monoclonal antibodies against the calcitonin gene-related peptide, which is inflammatory mediator. We have this monoclonal antibodies like serpinicimab, irinacimab. None of them, I don't think they have got that there. Anyway, it is not available in India, so they are not showing it there. Irinacimab, a few of them are available, which is not available now here. So we don't normally give that, and they are also too expensive. We have already told the non-pharmacological approaches to migraine, where you are identifying avoiding the triggers. Then we come to the tension type headache, which is the most common type of headache. About 30 to 78% of people will have had tension type headache sometime. The difference is that usually headaches is bilateral, around sort of dull, pressing type of headache, and it may be infrequent episodic or frequent episodic, or it may be chronic, with or without pericranial tenderness. They tell that when touch here there is pain, so there may be some tenderness. And then we have also got probable type where the number of attacks will be very low to really characterize it as tension type headache. Again, bilateral location, pressing or tightening, mild or moderate, it's not very significant, but it really affects your normal activities. Not aggravated by routine activities, no associated nausea, vomiting, photo or phonophobia. Treatment, smaller or milder attacks, infrequent attacks, any anti-inflammatory NSAIDs would be okay, like paracetamol, ibuprofen, naproxen. And those getting frequent attacks will need tricyclic antidepressants like amitriptyline or SSRIs like any of the newer SSRIs, fluoxetine. So, sertraline or any of those. Non-medication therapies like progressive relaxation techniques, biofeedback, hypnosis, acupuncture, etc. also may help. Now, for the patients, this is something that you should be telling the patients, do's and don'ts. Do seek medical attention, especially in those people who have severe headaches which is affecting their normal activities or normal life. recognize the triggers. They should recognize the triggers that cause the migraine. Keep a headache diary. Ask them to write the date, time, what duration of headache, and what are the precipitating factors that happen, or activities that they did during that day or one day prior to that. And then seek emergency help for the first headache. So the most dangerous headaches are those people having, while they are doing some activity, getting a sudden severe, the worst headache in their life. Most likely it is a subarachnoid hemorrhage. And subarachnoid hemorrhage, 40% of them will not reach the hospital. So somebody gets a headache like that. The first headache, I was brushing my teeth and suddenly I got this headache. Or I was lifting some weight and suddenly I got a headache. And for a few seconds I fell down unconscious and woke up. Most likely that will be a subarachnoid hemorrhage. So this is something that immediately they should go to the hospital. They can take a over-the-counter pain reliever. They should drink a lot of water, remain hydrated, take a break, go and sleep in a quiet, low-lit or dim-lit room. They can massage the scalp. If they have to recognize, they can just place the thumb on your temples and just move your fingers in small circles. This is something that you can tell them to do. They should recognize their triggers and then, if possible, causes, intensity and frequency of their headaches. Don'ts for the patient. Don't overuse rescue medications. None of this. I have seen some patients, someone among you must have at some point of time told them to take migranal tablet. You must have prescribed them to take migranal tablet, one tablet, and when you get headache. What has happened is they started taking it, they got relief. The number of headaches started increasing and they started taking it every day. I have seen patients taking migranal for last many years. That sort of thing is very dangerous, especially this type of migranal and where ergotamine is. It's very dangerous in patients having a stroke or having a coronary artery disease. So just be careful with that. So tell them not to overuse these medications. They should not delay seeking a headache professional for guidance and appropriate treatment. They should seek more stronger pain medications. They shouldn't look for stronger medications like opioids and anything. And they should not ignore signs of growing mood problems, mood disruptions, decreased cognitive functions. These are all indicative of any intracranial problems. And what are the do's and don'ts of physicians? Take a clear history. You should take a clear history, do a proper examination, do come to a clinical diagnosis first, do the necessary investigations, do advise non-medical steps, very important. And don't take it lightly. Headaches are not due to hypertension. Hypertension is due to headache. Don't investigate unnecessarily. Don't generalize treatment. So anybody who is getting a migraine, don't give them flunarizine. They will come back with so many problems. I have seen a small college girl who came with Parkinson's disease, Parkinsonism, within 3 weeks of taking flunarizine. Just 3 weeks. So just be careful about giving this. The patient may be very obese, and you give flunarizine or you give sodium valproate, they will even put on even more weight. So don't generalize the treatment in any of these patients. Don't fail to follow up these patients with headache. You don't know what it is. First time you might be seeing them headache, maybe something. Just ask them to come for a follow-up so that you will have an idea what is happening. If they're okay, fine. If they're not, try to think of some other alternatives and do not defer referral. Thank you for your patient listening.